Advocacy for better health is built on the premise that if citizens are aware of their rights and responsibilities, and civil society organizations have the capacity to empower and represent communities, they would have the confidence to hold their leaders accountable.
It is the duty and responsibility of the government of Uganda to provide health care for its citizens. Health is a right. It is not optional. And since the government has that responsibility and the mandate and the resources, it became necessary to have advocacy because we believe that within the government systems, there are improvements that can be made.
Empowered communities have the motivation to get organized, discuss and reach a consensus on their priority issues and plans, and to take action and demand for better health and social services from their duty bearers. Advocacy for better health has an objective of improving availability and accessibility of quality health services in Uganda. It supports citizens to demand for their rights and to be fully engaged in planning and monitoring of health services. In addition, it strengthens civil society organizations to conduct advocacy that can improve health-related policies, budgets, and programs. It also strengthens the institutional capacity of civil society organizations to obtain, manage, and implement long-term sustainable advocacy projects. It is implemented by PATH, Initiatives Incorporated, and 22 Ugandan civil society organizations covering 35 districts in western, central, and eastern regions of Uganda.
We do implement other programs, so many other programs, vaccines, immunizations, family planning, maternal and child health. So we use those innovations and ideas from those specific programs. Then we use the advocacy for better health to actually drive the advocacy.
The persistent collective voice and actions from citizens and civil society organizations compel leaders and duty bearers to respond by changing the necessary policies and taking other actions that can lead to improvements in the availability, accessibility, and quality of health and social services.
It became necessary to create a mechanism, A, through which communities can engage duty bearers, but also B, through which duty bearers can be held accountable to deliver on the quality of affordable services that they had promised they would be delivering.
It's a game changer. It helps everybody to realize his or her roles. And because of that interface, again, we understand each other better. Rather than everyone complaining, we find ourselves working for a common goal.
So Advocacy for Better Health was actually a platform for us in Uganda to try out the different innovative ideas that PATH has learned over the years in several countries and try to see what are some of those that can actually work in Uganda to actually improve the lives of especially women and children. And unless you actually talk to people, talk to the policy makers, talk to those who, make rain, unless you talk to those people who can move things, then you cannot actually make use of those ideas and different tools and devices.
So this project actually empowers the citizens with knowledge about their rights. We use the Patient's Charter, for example, which has been developed by the government of Uganda. We have disseminated the Patient's Charter, and by using the Patient's Charter to tell the people what they can expect when they go to a health facility, what they can demand for, what they should do, what they can do, even for them to participate to make sure that the management of their health facilities is improved.
The project is designed to directly contribute to improvements in delivery of services for HIV/AIDS, TB, malaria, nutrition, reproductive health, and maternal and child health.
We are focusing on 4 major areas of advocacy. We are focusing on domestic financing. We want to make sure that the budget for health is increased, and we would like to see the government of Uganda injecting more money in health. The healthier the people are, the better the economy will perform, the better the children will perform in education. Health is so central that by improving health, many things will improve on their own.
In some sub-counties, we do not have health centers. So the communities have been raising this to the teams when they organize meetings for advocacy for better health, and they say what we require here is a health center. We have been able to establish 4 health centers in underserved sub-counties. 2 of these are now fully functional. The one of Bufumbo in Jewa, actually it has a very high attendance of outpatients, and then another one in Bushiende, also very high attendance of patients. This all came through these community dialogue meetings where they raised this as significant issues, and it also helped me to use that for advocacy at central government so that they can approve the establishment of these health centers.
The second area is human resources for health. We want to see improvements in the way healthcare workers provide support to the citizens. We believe the motivation of healthcare workers is very important, but we also want to make sure that with the little that they are getting right now, they can continue to provide quality services. And then safety or security of commodities, healthcare supplies, medicines. When the medicine leaves the medical stores in Entebbe and it is headed for Mbale, does it get there? Right now we are working with 479 community groups in 479 sub-counties. We want to make sure that these groups are trained and empowered to be able to do advocacy. We believe in advocacy of dialogue, policy influencing advocacy, where we sit down and talk. So the people should be able to identify the issues, they should be able to identify the evidence, they should package it, and then they should be able to scale it up to their duty bearers or the stakeholders for dialogue. So we will be building the capacity of those civil society organizations.
We have awareness sessions in communities per sub-county. In every sub-county, we selected one active community group, an existing community group, that we introduced to this aspect of advocacy.
Over 400 community groups have been educated on their rights and responsibilities related to health and social services. The communities have been able to demand for policy changes from decision makers and to hold them accountable in provision of quality health services.
We have health facilities that never got medical supplies that are now getting medical supplies. Some of them got medical supplies from NMS for the first time in 2 years as a result of them being able to advocate for their rights.
One example is Jewa Health Center 3 in Mbale district, which never used to receive drugs from national medical stores because it was not appearing on their drug distribution list.
Twali tulina eddwaliro nga ddwaliro budwaliro naye nga temuliimu ki ddagala. Twatambuzza ekintu ekyo tutambula paka okutuuka ewa DHO nga tukaaba kiki kya ddagala, tukola public hearings, tuyita abantu sub-county number ne beewulirako ne batuwa ebirowoozo ne tubeera nga tubituusa paka ewa DHO paka ne mafooko nayo ng'etuyambako paka lwe twafunye eddagala ku ddwaliro.
If these meetings had not taken place, I don't think we would have been registered under national medical stores, because we were able to document some of the things that were mentioned in these meetings in form of minutes. Because even when we lobbied the district and Minister of Health, we were always attaching the minutes of these community meetings, the attendance lists, and that was evidence enough for Ministry to prove that really our communities had a need.
When advocacy has been made, people believe that actually the following day they are going to get the service. So I will receive like 100 requests here writing that we need essential medicines for this unit, for this unit, for this unit like this. Your health workers are this. So you find yourself overwhelmed. You find that, of course, some requests cannot be fulfilled and some are not realistic. So some of these have been the increased demand for services which is beyond what we can offer.
Advocacy for Better Health has been working with partners and the media to avert a national stockout crisis of anti-tuberculosis and HIV treatment medicines and supplies.
We entered into a partnership with Advocacy for Better Health to do a number of advocacy-based activities at the national and district level, so that the issues that come from the community are fed into the national level, and we are able to have better services for the constituency that we serve, which is for people living with HIV.
I would go with my recorder, get these voices, record them for about 30 minutes, and I don't edit them. We run this recording in the native language. Native language. If it is Rumasava, the program is Rumasava, is understood and listened to by the communities in their particular language.
Health workers will call me that the media team has come. They are capturing what is taking place here. What should we do? So those become like their disturbances to the health workers. But what I do is to tell them that be able to discuss, give them some little time, give them information, and inform them that the primary thing you are doing is to attend to these patients.
This is being done by raising both the national and international profile of the stockout crisis and working with networks of people living with HIV at national and district levels to collect evidence on stockouts in all the districts.
We have a team of people living with HIV on the ground. Some call them expert clients, others call them linkage facilitators or community support agents, who are actually supporting their peers at the health facilities, and they collect data. They are the people on the ground who give us the report on we have this stocked out, we have this available, or within 2-3 days we shall actually not be having any drug at all. But the bottom line is, even if it is 1 day, no single person who is adhering well on treatment should miss the drugs. We want total elimination of stockouts. We've been able also to engage the Minister of Health. We've engaged the Parliamentary Committee on HIV, and we are looking at how to ensure that all partners in the struggle actually play their role, and we do not have this issue of the stockouts.
Ruwera Health Centre 4 is one of the health facilities where a lot of success has been registered.
Eddagala eryo bwe lyabuliramuko basobola okubaako awalala we tulijja nga tukubayo ne batuwa eddagala, naye nga tufuna eyali badde afuna omwezi gumu ng'ofuna wiikisi 2, ennaku 3 bwe tutyo nga bagenda balobinga paka okulaba lwe batutereereza eddagala okusobola okuba nga lijja.
Eddagala ndifunira wano e Kasana, era bwe nazze nfunye bulungi eddagala lyange lya myezi 3. Omusawo mulabye eddagala lyange balimpadde bulungi. Tutu bwe najja akale nga ndi mulwadde nga sisobola na kutambula, naye kati nafuna amaanyi eddagala lyange ndimize bulungi, nfunye amaanyi kati nakamirira eddagala emyaka 4.
Actually, of recent, we had a very few stockouts of specific drugs, like I can mention a few, like Nevirapine 50 milligram base and the Calitra suspension. Calitra is a syrup that is given to children, but we were able to back up.
Whereas the issue of stockouts still remains, but the magnitude has completely reduced. And that's why we talk of sporadic. It is not something that is consistent. Like you go to a district and find that there are no drugs 1 month, 3 months, 6 months, 1 year, which is to be the case. Right now they are sporadic, and you do not find all the regimens lost. So what I can comfortably say is that working with Advocacy for Better Health, the support that we've been able to receive has been able to help us generate the evidence, which evidence we've used to advocate and engage and lobby and negotiate so that the drugs, whether it is following the normal routine, the normal cycles, or even if it is a quick buffer to alleviate a crisis here and there. We've also been able to get involved in the policy. Right now we've secured funding from UNAIDS to support the advocacy work that we started with ABH on developing a policy against HIV stigma and discrimination. We've been able to engage with the national medical stores. We have quarterly partners meetings so that we get feedback from national medical stores on what they are going through. Then we also provide the data, the evidence we've collected to see how we can work together. This is actually a partnership. It is not a blame game. We are tired of blame games. It's not a blame game. It is how do we support each other. If NAFOPAN has brought the evidence, then NMS now acts on that very evidence to be able to see, do I rely on a partner? Do I also supply an emergency buffer?
Reinvigorating Health Unit Management Committees, HUMECs, to provide an oversight role in the delivery of health services at health facility level is one area where Advocacy for Better Health is registering success in reducing staff absenteeism.
My roles here, I do monitoring on the behalf of the community. So they interested me. So with the other 6 people, we are 7. We do some monitoring of the service which is going on in the unity. We usually visit in a week. We can visit the unit about 3-4 days in a week. See what's going on in a week. Are the staff members working? Are they attending? And other things.
We do the mobilization. So as the Advocacy for Better Health came in the sub-county, they went to the sub-county, and the sub-county attached them to Gagai Women's Association to work together. We support them in the community mobilization. We mobilize the mothers to come for antenatal. Then we mobilize them to come and deliver at the health unit.
This one is 0.
This one is 0.
In Bugitima, we did have, there was only 1 bed. As we talk now, there are about 10 beds, new, purchased, after the communities were saying, no, we needed these things. So we held serious talks in that place. 2 months ago, I went back to Jewa Health Center. There is power in the unit. They have water, the tank. At least the lab is functional, though not well equipped, but at least it's there. As we talk now, they receive their own drugs, and they're into the process of making sure that they are filled into the national whatever. So at least I feel when we made a lot of noise, it happened.
In Sirongo district at Wijitima Health Center 3, a midwife had left delivery of babies in the sole hands of a night security guard.
The askari, the security command, the local security guard, would help, was the one who had now become as the midwife who would help mothers deliver. And he testifies it because I have even a recording for that.
Anganduire nembonete midwife karu myaka ajoki imwe indeda abesaris nga chiro bude nga basala chiro musigutike babonekara tananga nabona ngefura yakubrenjo yekali nichidimba bas uleo muyeda akulike
ndanga mwanzi ni mwana nikasaa neza kwenyuka mwiro sanga zitano kuchikupanga ko bitu kola kupanga ko bitu nga yobone byekwiga yasagako binanu kachi kyesi mupanga gireko basi kwatula kuza kudabula kwidwalo kodiyanga kako omusawo esizana eba musikale noliko ngendi bubi basi nayo kina nobanga okuyenda tebakendi kusobola kugendara.
Thanks to the active Health Unit Management Committee, the midwife was removed and a new one posted to serve in this remote community.
One of the areas has been to see that the health workers are available at their stations, and we have had many interactions with Advocacy for Better Health, where they have presented complaints from the communities on staff reaching late, staff leaving the stations early, and sometimes they are available but not doing their work. So this helped us to interact with the staff and say, we would like to see that work is going on. We would like a positive attitude towards the service you are offering. And we introduced also a monitoring mechanism, ensuring that there is daily attendance to duty registers, which from 2 years, 3 years ago, we started monitoring that, and we receive monthly reports, and then institute some sanctions and rewards based on the level of attendance to duty. And that has helped us to improve staff availability at the health centers and therefore community satisfaction.
The patient's flow in this facility has improved, tremendously improved. It has gone up, and people look to be more satisfied. The suggestion box complaints of staffs being rude, they used to write names of specific health workers, say so and so is too rude, so and so. The suggestion box these days we get only words of appreciation, appreciating some of the health workers. The clients who come here for services, their complaints are not as they were before. Now we get even appreciative comments instead of complaining, no health worker, no what. We are not yet at 100% yet, but what I know, we are different now as a health from where we are, with a few loopholes, but there is a difference from what it used to be.
Deliveries at health centers has increased from about 30% 4 years ago to now 65%.
Yeah, what I've seen from it, the service we are receiving, it is up to date now. You can see even the patients, pregnant mothers, they come in large number. But during those times when Atocho was there, they could not even come. They could come to me, chairman, we can't go there, because she even stood there and promised to inject them just water. They come and sometimes say hello to me. They say, chairman, at least the service we are receiving is up to date.
Before this project, we had the partial functionality of Busiu Health Center 4 in Mbale. Then after that, we got also a second health center 4 being fully functional. Then now the latest to come on board is Namatala Health Center 4, where Mafoko held so many meetings there. The doctors were very apprehensive. They could call on me. Now these people have called people for a meeting here. I said, no, you meet. You hold the meeting and you see what's the community saying. And they held meetings. And I want to tell you that at this point in time, they are offering a full package of services. It was a health center which had never operationalized its theater. It is now about 8 months they have been carrying out operations just because of these interactions, and they try to understand what the community needs.
Lack of staff housing, one of the major causes of health work absenteeism, was solved by completing a house where the midwife currently resides. Advocating to reduce health work absenteeism and improve relationships between clients and health workers leads to better health outcomes.
When they came in to advocate for better health, they found many of our centers not having boards, what we would call health unit management committees. And those who had, they were dormant, or the leaders really didn't know what their roles were. So they worked very hard that the boards were appointed and they were taught or trained on what their roles were. And that has improved so that we don't clash too much with the community. Once we talk to the board, the news can go out and people will understand that we are trying all this.
In Mpigi Health Centre 4, 2 more doctors have been recruited. With such a busy health facility, more doctors mean round-the-clock operation in the theatre, where mothers and babies in danger are saved through caesarean delivery.
Because as I stand now, the staffing norms, I'm actually at about 100%. But given the work I do, I should be having a staffing norm of the hospital. So we are advocating, we are working very hard for the powers that be to note that we need to go to hospital level so that the staffing levels will improve. I know we have advocated for doctors because I wouldn't manage with only 2 doctors in this center. We are now 4.
In Mbale district, community advocacy is improving health financing.
Sometimes the staff are reaching late because they stay very far from their stations. And because of these interactions, we had to advocate with the district to see that using various grants, we are able to prioritize health and construct some staff houses. So we constructed 24 housing units under the Office of the Prime Minister and SAF 2 project in order to have some of the staff resident at their health facilities.
Bujiri District Nankoma Health Centre 4 is improving staff housing.
It was sad to note that 2 doctors were sleeping in the same house. But as a result of your activities, we've received a donation that is by Gavi. I think they had your cry out. They are constructing 2 apartments to accommodate the 2 doctors so that at least they all live independently. I think that will improve services if we have resident doctors at the facility.
Community members have been empowered. They now regularly monitor and track availability of medicines and health workers to ensure there is provision of quality health services.
We do tracking at this facility on a monthly basis. The reason as to why we do track is, 1, we want to know the number of staffs available. We want to see and know the number of staffs who are present on a particular day or in the whole month. We want to know the time and arrival of the health workers. We track to get information on the stock. In every quarter, we conduct 1 advocacy forum meeting. So we get this information we've got from these tracking tools. We present them. We write a paper and a position paper. We present them to the duty bearers or the stakeholders in the advocacy forum meeting.
We have had at least a constant supply of Coartem without serving. If we get any malaria personnel, there is Coartem available because we get more stocks.
We cannot do it alone. Advocacy is a group effort. It is a team effort. We cannot do it alone. And as long as we don't have a cure, we don't have a vaccine for HIV, then we must be able to continue this work until we have total elimination of stockouts.
We've seen, attitude of health workers improving because of the communities being aware of the way they're supposed to be treated, the hours health workers are supposed to work. So we are seeing a change.
We want to make sure that there are policies on these issues. We want to work with government to socialize the 90-90-90 HIV, AIDS, and TB treatment guidelines. We want to make sure that these are socialized in the communities. We want the men to come forward and be able to partake and participate in these services. So we want to make sure there are significant improvements in MCH, in HIV, AIDS, in TB, nutrition. Uganda right now is going through a hunger problem. We want to make sure nutrition in this country improves. There needs to be a nutrition action plan. There needs to be a policy that is implemented and rolled out. Districts should be able to take responsibility for implementing government policies and making sure they deliver what the government has promised to the citizens.
Sustaining the successes of advocacy for better health and its unique community empowerment and policy advocacy models will require building stronger coalition among civil society partners, increasing awareness of citizen rights and responsibilities, and maintaining traction on policy engagements. This will ensure attainment of goals under human resources for health, domestic health financing, and health commodity security.